Welcome to the Putnam County Library Lunch and Learn. Today we are joined by Ashley Cohen, who will be discussing using genetic testing to assess cancer risk. Take it away, Ashley.
Thank you so much for having me today. So today my presentation is titled Beyond Family History Using Genetic Testing to Assess Cancer Risk. So today I will be going over what genetic counseling is. I'll give some presentation on hereditary cancer cases. We'll talk about increasing awareness of genetic testing scams. Unfortunately, that has been prevalent, not only locally, but also across the nation. And we'll talk about some common misconceptions about genetics. Now, if you all have any questions, there might be a way for them to submit them via social media, and I'll be happy to answer those questions after the presentation. So to start, what is genetic counseling? So genetic counseling is the process of helping people understand and adapt to not only the medical, but also the psychosocial impact of genetic testing results. So of course, it's important to understand, what does this result mean for my health? What does this result mean for the health of my family members? But my job is also to help that patient navigate through what that particular result means for that patient at that time. So a patient who comes in that's 18 years old with a positive result is very different than a woman who is 65 years old with a positive result. So we help kind of navigate through what these results mean for that particular patient at that time in their life. The other aspect of my job is interpreting family and medical histories to see what is the chance of there being something hereditary going on in the family. Most of the time, as we'll see through this presentation, most of the time cancers specifically are not genetic, are not, I guess let me clarify, is not hereditary. Most of the time they are due to unknown causes or sporadic causes, but sometimes there is that chance of it being hereditary. So we take a look at all that history to see what is the chance of that being hereditary. We'll talk about the inheritance pattern, meaning how is this being passed down through the family. Testing options, medical management for patients who do test positive, and importantly, for patients who test negative. What does that negative result mean on their medical management? Talk about prevention options, resources, and research options, and then again, that counseling aspect. So my background and the background of a genetic counselor is typically we have our bachelor's of science in some sort of biology. So I have my bachelor's of science in microbiology from the University of Georgia, and then we all have our master's of science degree in genetic counseling. I received my master's of science from UAB. We have expertise in medical genetics and psychosocial counseling. So a lot of our courses are actually truly 50-50. We have half of the courses be very medical driven, genetics driven, and then the other half of those courses we learn a lot of those counseling skills. And then we are board certified and we are licensed here in the state of Tennessee. So genetic counselors actually practice, and now especially 2025, in a wide variety of different areas. So my specialty now, and has been since I graduated grad school, is hereditary cancer. But you can see from the presentation here, there's many areas that genetic counselors can practice in, and this probably even now doesn't describe all the different areas genetic counselors can practice. So there are prenatal genetic counselors who will help navigate through abnormal ultrasound findings during pregnancy. From a pediatric standpoint, we think a lot of maybe Down syndrome, some of those chromosomal abnormalities. Neurogenetics, where they take a look at early onset Alzheimer's, Huntington's disease. There's metabolic disease, general genetics testing. So there are genetic counselors who work in genetic testing laboratories, or in what we call in a non-patient facing profession. Adult genetics, cardiology. I would say cardiology is probably right behind cancer in terms of how prevalent genetic testing is being used in that area. There are genetic counselors that work in reproductive technology and infertility clinics, pharmacogenetics, which I think is particularly fascinating field where we're taking a look at a patient's genetics to determine how they're going to respond to certain medications. So this is particularly used right now in the field of like mental health drugs. So for depression, anxiety, those sorts of drugs, they're looking at a person's genetics to see, do we need a higher dose of this medication for the patient? Do we need a lower dose of this medication? Or are there certain medications that we want to avoid for this particular patient based on their genetic makeup? And that is to help with the trial and error process of trying to find a good dosage for patients, because that can be a challenge sometimes. Genetic counselors practice in psychiatric medicine, direct-to-consumer testing, education, genomic medicine, undiagnosed diseases program, which is a pretty interesting program where, unfortunately for patients who have been on the diagnostic odyssey of trying to find an underlying diagnosis for their condition, and have been to many doctors, have had many tests, unfortunately still can't find an answer. These undiagnosed diseases programs try to get all these experts in various fields to come together to see if they can help diagnose this patient, and genetics is a part of that. So what is the genetic counseling process? That's another question I get all of the time. So step one, of course, you can schedule the appointment. Step two is prepare for that appointment. So prior to meeting with that patient, what we'll do is go through that patient's medical records to see, okay, do we think based on what we know ahead of time, is this suspicious for an underlying genetic cause, or are we not suspicious? Then we'll meet with the patient, go through an extensive outline of that patient's medical history and their family history. We will take what we call a pedigree, which I'll show you here in the next couple of minutes, where basically it's a family tree for that patient that shows what type of cancers are in the family, the ages people were diagnosed, and how relatives are related to each other. If that patient qualifies for genetic testing, what we typically do is the sample collection that same day. That is either going to be a saliva sample or a blood draw, and that sample will be sent to the genetic testing laboratory. Those results typically come back in about 3 weeks. We'll go over those results with the patient via phone call or in person, depending on patient preference. And then of course we'll send everything back to their referring doctor. And so if there's any particular cancer screening recommendations or anything specific, their provider can then order those tests or screening there. And then of course follow up after. So there are benefits and limitations to genetic testing. I always tell people, of course, I'm very biased in that I think genetic testing is a very beneficial thing for not only an individual but their family. But there are some downsides to genetic testing too. So the first benefit of genetic testing is that it can be empowering for patients. It can finally provide a patient or a family with potentially some answers of why is this happening in me or my family members. And it can give relief from uncertainty, meaning that they have had all these questions and not knowing what to expect can sometimes be the hardest part, but now we have an answer for that. It can help guide cancer treatment options and cancer prevention. So that's the biggest key, I think, in genetic testing, that results can be used to help prevent cancers in relatives who are unaffected, but can also be helpful for people who have a history of cancer to say, okay, based on your genetic makeup, would you qualify for certain types of treatment options? And then of course the implications for family members and for family planning. The limitations of genetic testing can sometimes be the psychosocial impact of results on the patient and their relatives. So getting a positive result or even getting a negative result can sometimes be very difficult for a patient because they were either looking for an answer and they didn't find one, or we found an answer, but of course a positive result opens up a whole nother set of implications for that family. Negative result does not necessarily reduce the risk of cancer in a family. So a lot of the times what we go through with patients is saying that, okay, even though we got this negative result and it's a good result, it still doesn't take away your family history of cancer. And so based on that family history, you still have a high risk for, X, Y, and Z cancers. So that sometimes can be a downside of genetic testing. We can find incidental findings This is hopping up a little bit more and more in my practice, where we do genetic testing, typically with these big hereditary cancer panels that I will also show here in a couple of minutes. And when we do those big panels, the benefit of doing the big panels is that we try to test as much as we can. The downside of doing those big panels is that sometimes we find these incidental findings that say, you tested positive for a gene mutation in a gene associated with hereditary kidney cancer, but there's no kidney cancer in the patient or their family. So it's a very surprising result to get that doesn't quite make sense in the family, but can still be helpful for that individual. The interpretation of some of these other genes, especially when we do this big panel, can be really complex, because some of the genes we know a lot of information about, other genes we don't have as much information, and that can be a challenge in interpretation. And of course, the limitation is that knowledge of genetics is growing so rapidly that all of this changes very quickly. So it's important to keep up to date with your genetic counselor. So when we think specifically about hereditary cancer testing, here's a list of indications where it might be beneficial for someone to consider genetic testing. So when we see cancer in 2 or more close relatives on the same side of the family, when we see early age of diagnosis of cancer, whether that be diagnosed before age 50 is kind of typically the cutoff. I don't really want to say cutoff either, but typically where we see, is this more suspicious or less suspicious for a hereditary cancer? When we see multiple primary cancers in an individual or family, when we see bilateral or rare cancers, and then you can see there is a big list of specific cancer types that even just one diagnosis in the family is enough to suggest genetic testing may be beneficial. So that could be for male breast cancer in a family, ovarian, pancreatic, metastatic prostate cancers, metastatic breast cancers, triple negative breast cancers. All of those cancer types are more uncommon. So when we see them, that's when we think maybe there's more likely to be a genetic cause. And then when we see colon polyps, typically 10 or more of those, that could be suggestive of an underlying genetic cause for those colon polyps as well. So what's important to know is that all cancer is genetic. That's what cancer is. It's a series of genetic mutations that then evolve into this tumor that develops, right? But not all cancer is hereditary, meaning that this gene mutation has been passed down through the family that's increasing individuals' risks for cancer. So here's a good illustration to show different things that can increase a person's risk for cancer. Of course, hereditary being number 1. Number 2, UV radiation, which we know sun exposure can increase the risk for skin cancers. Chemicals, so for example, maybe if your relative is a farmer and there were fertilizer exposures, or was a relative was in the military and was exposed to Agent Orange, those can increase the risk for certain types of cancers like lung cancers and prostate cancers. Viruses can increase the risk for cancer as well. So specifically we think of like HPV can increase the risk for cervical cancers. Smoking, of course, we know can increase the risk for lung cancers. And of course, just cells dividing rapidly is cancer itself. So this is another good illustration here to show, again, that most of the time cancers are not hereditary. Most of the time they fall into the sporadic category, where it's due to those environmental exposures or unknown causes. That blue slice of the pie here shows that hereditary component there. So about 5 to 10% of the time our cancer is hereditary. There is this piece of the pie that's called familial cancers, and that we suspect is a combination of genetic and environmental factors that together increase an individual or family's risk for cancer. So a good example of a familial condition is when we see heart disease run in families, we see diabetes run in families. We know that there's probably some underlying genetic component there, but we also know that those environmental exposures that are shared within a family can also increase that risk. So a familial cancer is kind of an in-between risk there. So there are certain types of cancers that are more likely to be hereditary than others. So you can see right here in this chart, that ovarian cancers, when we see an ovarian cancer in a patient or a family, we know that there is an increased chance that there could be something hereditary going on there. So with ovarian cancers, we think a lot of the BRCA genes that you all may have heard of before. When we see stomach cancers, that's a more uncommon type of cancer. So when we see that, it makes us more suspicious of there being an underlying hereditary cause. Of course, breast and prostate cancer are kind of equal there. Lung cancers are more likely than not hereditary, but there is one particular gene called the EGFR gene, and mutations in that gene can increase the risk for hereditary lung cancers. But those lung cancers are actually typically very early onset, so before age 50. And typically those individuals do not have a smoking history there. So that's when we think of that particular gene. But you can see on that chart there are other cancer types that can be hereditary too. So now I want to transition a little bit and talk about particular cases that I have seen. So this patient is a 35-year-old female. And if I point to this, will they be able to see me pointing?
Yeah.
Okay, perfect. So this patient is 35. You can see she is listed right here. Circles in this pedigree are females and squares are males. So this is the female patient here. This is her mother. This is her uncle and her two aunts on her mom's side of the family. Cousins are all grouped together right here. At the top, you can see her grandfather and her grandmother. This is the patient's father, her uncle on her father's side, her cousins, and then her grandparents again at the top. So this particular patient, in terms of her family history, had a maternal aunt with ovarian cancer, a maternal grandmother with ovarian cancer, maternal grandfather with lung cancer. As we just saw in the chart a couple slides ago, we know when we see ovarian cancer in a family, we say, okay, that's a little bit suspicious of there being something hereditary going on. When we see two ovarian cancers in the family, that makes us very suspicious. So I know that you all will not be able to see this chart here, but I put it up here because I want you to kind of see how broad of a test we typically do for genetic testing. So on this side right here, you can see a variety of different gene names, and here it shows what cancer types are associated with those particular genes. So again, I know you can't see the gene names, but it just gives you an idea that it is a big cancer panel that we order for these patients nowadays. So this particular patient had genetic testing, and she did test positive for a BRCA2 mutation. So that we know explains her family history of ovarian cancer. So I'm sure you all may have heard Angelina Jolie has, I can never remember what mutation she has. I believe it's a BRCA1 mutation, but she tested positive some years ago, and then Beyonce's father actually was diagnosed with male breast cancer. He did genetic testing, and he is also BRCA positive. I don't know the results for Beyonce, but I do know her father is positive. So this is a breakdown of the cancer risks associated with the BRCA mutation. So the risk for breast cancer in a woman with a BRCA mutation is as high as 87%. I will say these slides are a little bit dated, and that nowadays the quotes are more in the 60 percentile risk for breast cancer, but still goes to show that risk for breast cancer is very high compared to the 12% general population risk. So the gray is the general population risk for those cancers. This is the risk for a woman with a BRCA, man or woman with a BRCA mutation. So the risk for ovarian cancer in the general population is about 2%. The risk for ovarian cancer in a woman with a BRCA mutation is as high as 40%. Male breast cancer risk is increased. Prostate cancer risk is increased. Pancreatic and melanoma cancers as well. So the way that this mutation is inherited through the family is called autosomal dominant inheritance. So all that means is that if your parent tests positive, And we can see in this illustration here too. So this father is positive. The mother does not have the mutation. So there's a 50-50 chance for each child, whether they be male or female, to have that BRCA mutation. So we know that this mutation for this patient was either inherited by her mother or her father in general. Here, I know that you all probably can't see these guidelines either, but this is an outline of the recommendations for people who test positive for a BRCA mutation. So from a breast standpoint, what we would recommend is breast screening every 6 months, alternating between a mammogram and a breast MRI, or to consider doing a double mastectomy where we proactively remove the breast tissue to reduce that risk for breast cancer as much as possible. From an ovarian perspective, we're a little bit more straightforward in saying, given the risk for ovarian cancer, and because we don't have good screening for ovarian cancers, we do recommend having the ovaries removed typically between 35 and 45 and after that woman is done having children. From a male perspective, because one of the common questions I get all the time too is that, is this important for men to know as well? And the answer is absolutely yes. So men who test positive for a BRCA mutation, they can start doing mammograms if there is enough breast tissue for them. But of course, the self-exams would be very important for them too. And then starting prostate cancer surveillance at an earlier age is recommended as well. So for this, going back to this particular case, which I don't have her pedigree here, but going back to my initial patient that was 35, unaffected, had 2 relatives with ovarian cancer. What does this mean? So this mutation likely explains her maternal family history of ovarian cancer. The reason why I say likely explains is because we don't know for certain, because we have not tested those relatives, but with a strong educated guess, you could probably assume that those relatives probably had that same mutation as well. But as you can see, testing is always recommended for confirmation. We know that this increases my patient's risk for breast cancer, ovarian cancer, and pancreatic cancers. So we do need to start doing those screenings for her. With her being 35, she could start considering to have her ovaries removed in the next couple of years. There are screening options, risk-reducing medications, and preventative surgeries available, as we discussed. And then now the next steps are for family members, which let's go back to her pedigree. So she has no children, so nothing that we would need to be worried about for her children since she doesn't have any. But like I said, we know this either came from her mom or her dad's side of the family. So in this particular case, what we would recommend is testing for the patient's father. The reason why that's beneficial is because if her father is negative, then we know for certain, and I guess maybe I don't want to say for certain, but again, we can take a strong educated guess that her mother is the one who tested positive for that mutation that was passed on to her daughter. And then that's how those other relatives are affected. Actually, in this case too, her maternal grandmother is still living. So that would be the next best person to test there as well. Perfect, so let's go to this next case here. So for this next case, this is another patient I saw. She's 65 years old. She has no personal history of cancer. So I'll walk through her pedigree again. So this is the patient. She has 3 adult male sons. This is her sister, brother, her mother. Her aunts and uncles are kind of grouped in all together. So the diamonds represent many relatives together. So here we know that she reports 7 close aunts and uncles with colon cancer, and then 12 cousins with colon cancer. We see that her maternal grandmother had colon cancer in her 30s. I forgot to mention her brother had colon cancer at 26. And then her father reports prostate cancer in his 60s, but there's no other cancer history on her father's side. So looking at her family history, of course, we see very young colon cancers in the family. So again, we ordered a big hereditary cancer panel on her, and she tested positive for an MLH1 mutation. So I've talked a whole lot about the BRCA genes, but outside of the BRCA genes, the most common cause of hereditary colon cancers is actually this condition called Lynch syndrome. Lynch syndrome is associated with 5 different genes, so you can have a mutation in any one of those 5 genes and have Lynch syndrome. So MLH1 is one of those genes that is associated with Lynch syndrome. So Lynch syndrome can increase the risk for various cancer types, as you can see by this chart here. But the big ones are going to be colon cancer, ovarian, uterine, and stomach cancers. Those are the big 4 cancers we think of for Lynch syndrome. So here again, you can see there's that increased risk for colon cancer with Lynch syndrome. This is that general population risk, so you can see the significant increased risk. With the uterine and the uterine endometrial cancer, same thing. Risk that is much elevated over the general population risk. Ovarian, stomach, small bowel, and those urothelial cancers. So for this patient, I guess before we go there, the inheritance pattern is the exact same for Lynch syndrome as it is for a BRCA mutation. So again, it's that 50-50 chance that could be passed on to relatives. So again, this is the management guidelines for a patient who has a Lynch syndrome. It's probably very small to see on the screen, but we do know with Lynch syndrome, we need to start colonoscopies at an earlier age, typically between 20 and 25, and repeating those every 1 to 2 years to stay on top of that colon cancer risk. From an endometrial or uterine and ovarian cancer risk, typically the recommendation is to have your uterus and your ovaries removed, generally whenever you're done having children between 30 to 35. From the urothelial cancer risk, typically they do an annual urine analysis between 30 to 35. The gastric small bowel cancer risk, they typically do the upper endoscopy to take a look at those organs as well. You can see there's screening recommendations for the pancreatic cancer risk, prostate, breast, brain, and skin cancer risks too. So there's very clear guidelines of what we recommend for people who test positive. So going back to my patient, and let's see her pedigree again. So for her, I can't recall if she had her uterus or ovaries removed or not, but if she had not, she certainly would need to do that. She would need to start doing her colonoscopies every 1 to 2 years. She does have 3 adult sons here that I wanted to illustrate. They all are now candidates for genetic testing to also see if they have Lynch syndrome. And then of course, testing for her siblings and her niece and nephew as well will be very important for the entire family to know. So let's see. So this again means this mutation likely explains her maternal family history of colon cancer, but testing for relatives is always recommended for confirmation. We know it increases her risk for colon, ovarian, and uterine cancers, so we'll have to talk about screening or surgery options for those, and again, the risk for her relatives. So that kind of concludes the case presentation for this hereditary cancer risks. But I also wanted to switch gears a little bit to talk about genetic testing and what options you have available to you. So what's important to know is that not all genetic tests are created equal. So the genetic testing that I do and that your doctors would do is what we call medical grade genetic testing, where the information and testing is very well protected, that we're testing for appropriate genes, and the testing is very thorough. There are many other options out there, some that we call direct-to-consumer testing, where you can order a genetic test, do it yourself at home, and get whatever results for whatever test you choose to do. There are limitations of direct-to-consumer tests versus medical grade tests. For all of my patients who come to me saying that they've already had a 23andMe or various other types of tests, we always have to do medical grade testing to confirm either those results, and more than likely the tests are very different, that genetic testing really wasn't done when you're doing direct-to-consumer tests versus the medical grade tests. So just be aware that even if you think you've had genetic testing, if you've done that in the past, it may not be kind of that, what we call that medical grade testing. The other thing that I wanted to share with everyone is that there has been, unfortunately, an increase in scams related to genetic testing. So this was actually put out by the Office of Inspector General. I don't know if it's listed on here, but it was a couple of years ago that he posted, or that they posted this regarding genetic testing scams. So what to look out for. So scammers typically offer cheek swabs to obtain an individual's Medicare information for identity theft or fraudulent billing. So this testing is not ordered through a doctor, and most of the time is not medically necessary. I've actually had come across a couple of these cases where individuals thought they were doing the right thing by doing genetic testing for their family, but it was actually a scam that they were involved in, unfortunately. And so here are some of the warning signs. So who they typically target is Medicare beneficiaries. They typically target via telemarketing calls, public events, health fairs, or going door to door. Another red flag is if you say, you know, you can do genetic testing done every month. That is not true. Genetic testing, in theory, should only be able to, you only have to do it one time because your genetics never changes. So that would be a warning sign to be aware of as well. So how can you protect yourself from fraudulent genetic testing? So if a kit is mailed to you, do not accept it unless it was ordered by your doctor. Be suspicious of anyone who offers you free genetic testing and then request your Medicare number. A physician or genetic counselor should approve any request for genetic testing. Medicare beneficiaries should be cautious of unsolicited requests for their Medicare number. And of course, if you suspect any fraud, contact the OIG. And then I want to wrap up here by talking about some of the misconceptions that I come across a lot of the time about genetic testing. So one of the common things I hear all the time is that and actually I'm hearing this less and less over the time, so that's good. But my father's side of the family history doesn't count. That is not true. A paternal side of the family history is equally as important to know as your maternal side, because we know we get half of our DNA from our mother, half of our DNA from our father. So both sides are absolutely equal in trying to understand a person's risk. I've already been diagnosed with cancer, so I don't need genetic testing. That's also not true, like we talked about a couple of minutes ago, in that genetic testing can be used to help determine, number one, are you at an increased risk for other types of cancers? And if so, what can we do to reduce those risks for that patient? But also nowadays, genetic testing results can be used by your doctors to determine if you qualify for certain treatment options. Broken genes skip generations. Now I hear this one a lot for sure. So I wanted to show this pedigree of that patient we talked about a little while ago. So for this particular patient, we know that she is BRCA2 positive. And again, we know it either came from her mother or her father. Now, we're going with the strong educated guess that it's coming from her mom's side of the family. So we have to assume that her grandmother is positive, her aunt is positive. The only way this patient could have inherited that mutation is through her mother. Now, her mother's 58 years old, she passed away at 58 years old with no cancer history. So it can appear like it skipped a generation because her grandmother had the mutation and had cancer, and the patient is positive, but even though it appears that way, we know that her mother had that mutation because these do not skip generations. She just never developed a cancer either before she passed away, or it's possible that maybe if she lived until she was 90, she never developed a cancer. You can have these mutations and never develop cancer, but what we do know is your risk is higher than what we would anticipate. And then genetic testing is expensive. If you came to me 10 years ago, yes, that was absolutely true. It was thousands of dollars, but nowadays we can do that big hereditary cancer panel that I had shown you for a max of $250, which for most patients is reasonable. And for patients that is still a large expense, there are options that are available. So I tell patients, never let cost be a barrier for genetic testing, because that's certainly something we can work through. And then I've already had genetic testing, so I don't need it again. That one's kind of true, kind of false, like we talked about. You really don't need it again, in the sense that, again, your genes don't change. So you don't need to repeat the testing that has already been done unless there's been a major improvement in the technology to detect those mutations. But what we're finding and discovering more and more genes over time. And so if you didn't have certain genes tested 10 years ago, now's the time to do that additional genetic testing for things that were not tested for in the past. So that's that one, the pedigree. And then I put this little comic here because I thought it was pretty cute. But I also have my contact information on here, so that way if anybody watching has any questions or is interested in doing genetic testing, feel free to reach out and I'm happy to answer those. Thank you.
Thank you, Ashley.